Good morning, everybody. And we do apologize for starting a little bit late this morning, but I understand you had a phenomenal session downstairs. So in light of that, I think it's bumped all of our schedules back a little bit. My name is Rick Murphy, and I'm the president of North American Management, and I welcome all of you here this morning for this most exciting session. I usually don't get an opportunity to moderate these types of sessions. Yesterday, there was a group from Boston, and I think I'm from Boston and I have my Boston accent, that they felt that I was the most appropriate person to moderate that session. And today, our session is caring for aging population, and I'm not quite sure why they selected me to moderate this session, but I think we might be able to draw some conclusions to that. We really have a phenomenal speaker this morning. Tara Cortes is recognized for her distinguished career spanning executive leadership, nursing, education, research, and practice. She is currently the executive director of the Hartford Institute for Geriatrics and a professor in geriatric nursing at the New York University College of Nursing. Dr. Cortes has provided significant contributions to advance the health of people, particularly those with limited access to the healthcare system. Importantly, she has developed collaborative models with advanced practice nurses and physicians in traditional as well as non-traditional settings to enhance the care of American elderly population. The consistent theme across her work is the essential role of advanced practice nurses, improving the quality of life in specific patient populations, and the interdisciplinary nature of health care. Dr. Cortes is a leader in developing, evaluating, and implementing advanced nursing practice and collaborative practice. Now, her bio is very, very long, and I think it's important that you all understand the importance of her work, which she's contributed to advancing interdisciplinary models across the continuum of care to reduce the disparities in access to care and to ensure health aging in place. Prior to joining New York University College of Nursing, Dr. Cortes was president and CEO of Lighthouse International, a leading not-for-profit organization dedicated to fighting vision loss and helping people to prevent vision impairment. Dr. Cortes spent the initial phase of her career in nursing education at Hunter College, and then as the head of nursing research and information systems at Columbia Presbyterian Medical Center. She was the chief nursing officer at Rockefeller University Hospital and continued her career in nursing and hospital administration at Mount Sinai Medical Center and at Bridgeport Hospital, before assuming the senior leadership role at Lighthouse International. So we really do have a national leader here today. I thought it was important to go over their bio so at least you get a sense of who she is. So as she shares with you some of the things that she's done, some of the areas in which she's practiced in, and some of her knowledge, you really get a good, strong base that this is a person who can really shed a lot of light on the area of aging. And without further ado, Dr. Cortes.
Sure. Sorry, I'm ruining Rick's wonderful introduction. I want to make sure, for those of you who are interested in continuing education credits,
Great.
Just raise your hand. I'll make sure you get a form when you get started.
That's fine. Thank you, Casey. Well, thank you, Rick. I feel the benchmark here is very high now for this presentation, so I hope I live up to it. But it's a real privilege to have you as our moderator, and thank you very much for being here. Boston aging, I'm glad you all fit into your role. Well, it is, and I must have stepped on something here. I thought I'd turn down the volume. It is a pleasure to be here with you all today, and it's a particular pleasure because this is it's a group that I'm not as used to speaking with, because normally I'm speaking with nurses, physicians, and I just think there is such richness in having the representation here from the consumers, the providers, administrators, and also the diversity of the population which you represent. As you heard, my passion is about providing care to those who have poor access to care. And as I go across this country, I'm shocked. We all kind of think of healthcare as healthcare. And when you go across the country, you understand how complex the Affordable Care Act has to be, how complex delivering healthcare in this country is, because we have a very, very diverse population. Culturally, every state of the country is a different culture, and that in itself is a variable. plus the economics of each state, the state regulations everywhere, all impact what you all do, what we all do. So it's a unique pleasure for me to have the opportunity to be with you today. The reality of the 21st century, and this is no other force, is likely to shape the future of national economic health, public finances, and national policies as the irreversible rate at which the world's population is growing older. And it is not just the United States population that's growing older. There are countries all around the world that are having this problem. Italy, for example, 1 out of 4 people in Italy is over the age of 65. Japan, 1 out of 4 people are over the age of 65. And they are not replacing that population with the younger population, as we will not be. We have the baby boomers turning 65, and we're not, the replacement factor of our younger population is just not there. So the growing number of older adults, there's basically 3 things I'm going to cover today. One is the impact, what this growing number is all about, and what the impact is on healthcare. The second piece is our workforce, and what does our workforce look like to address this health need of our older adults that are just growing and growing. And lastly, I'm going to talk a bit about a program that the Hartford Institute is launching, and we've been working in the collaboration with Alex Lair and the Community Partners for Sustainability. And we will be rolling out some of our resources to many of you that are sitting here in the room and are in this symposium today. 2013, here's where we are today. We've got about 35 million people in this country who are 65 years or older. That's about 16% of our population. By 2030, that number is doubling, more than doubling. It'll be 1 out of every 5 people in this country will be over the age of 65. Nearly 8,000 people are turning 65 every day right now. This is that baby boom. This is the baby boomers have hit. I've even heard just recently 10,000 people. So somewhere between 8,000 and 10,000 people are turning 65 every day. People 75 years and older use 3 to 4 times more hospital days than people 44 to 55. That's amazing. 3 to 4 times more hospital days. And 25% of our Medicare patients are readmitted to hospitals within 30 days. People 85 and older spend about 5 times more on health care than people 45 to 55. And one of the big reasons for that, which I won't go into in the course of this paper, but one of the big reasons for this is end-of-life care. In the last 6 months of life, we spend more than $60 billion on health care in the last 6 months of people's lives because we don't know enough, we don't understand enough, we haven't taught enough about hospice and palliative care, and how to alleviate people's suffering through palliative care, but how to help people die comfortably with dignity with hospice care. Challenges. Typically, older people are sicker with higher acuity and more comorbidities, and certainly you understand that. Multiple chronic conditions, as we just heard about in the plenary session this morning, multiple chronic conditions are driving healthcare costs in this country. Hospitalizations for older adults are longer. They lose both cognitive and physical function during hospitalization, and that to me these are avoidable loss of function. You take a person 85 years old, you put them in the hospital and let them sit there in their beds for a day or 3 days, they come out on a walker, never able to be independent again. So we have a real issue going on, which we're trying to address that over the years. The Hartford Institute has been working with how do we keep cognitive and physical functioning for people when they're hospitalized. We lose muscle as we get older, and we lose much more muscle when we're not moving. Older adults are more susceptible to those never events, like developing things like urinary tract infections, falling and with injury, or getting pressure ulcers when they're not moving around. Changes on medication regimens, polypharmacy, often result in delirium and cognitive decline. When people have their medications changed, and I just was talking to someone or heard someone say yesterday they were on 22 medications. I think it was in one of the sessions. This is polypharmacy, and those are the things that cause problems and functional decline in older adults because they are really over-medicated. And then, of course, we have the fee-for-service structure. And I just heard this morning about the exchanges rolling out with a fee-for structure, and she said for now. And we've got this going on around the country. You know, is fee-for-structure the right model, or should we really be going to managed care for all? More challenges. Healthcare costs are soaring. Healthcare costs were 17.6% of our gross domestic product last year. Almost a fifth of our national money is going toward healthcare. This is 1.5 to 2 times more than any other country in the world, and yet we rank 20th in life expectancy. You know, you think with all this money we spend, we would have the healthiest country in the world. Well, we don't. We are 7th in mortality in cancer, so there's 6 countries better than us in mortality. Why are we 7th and why aren't we number 1? Because we do not practice preventive medicine. We don't do those things that we need to do to prevent cancer from occurring. So once we detect it, we're number 1 in treatment after diagnosis, but we do not do a good job in diagnosis. Why? Because we have traditionally had a model here, a paradigm in the United States on acute care. We treat episodically. We do not treat preventively. And as I listened to many of you in the last day here, and again this morning, I hear the issues, though, the issues of getting a lot of people to even think about healthcare, to come into your clinics, to come into healthcare centers. So many of you are doing activities that are house-based, residence-based, and these are very important because it is a way of engaging the person and then getting them more involved in their preventive care. Our healthcare system's attention, as I just said, on acute care. The selected risk factors for Americans 65 and over, well, 32% are obese. A third of our people over the age of 65 are obese. 10% are smokers. 55% of all men and 31% of all women are former smokers. Smoking is a terrible thing. And in prevention, one of the first things we need to do is get people to stop smoking. The average time spent watching TV is 4.1 hours a day. And we heard this morning about that push for activity, 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 part of the Affordable Care Act, get people active. When you sit in front of the TV for 4 hours a day and then you eat and then you sleep, you're really not getting any activity. 1 in 4 people over 65 has at least one limitation in bathing, dressing, eating, walking, or using toilets. Now, that's a surprise to me. I just don't think about that when I think of 1 over 65, so someone who's 65 or 66, 1 out of 4. And 1 out of 4 has diabetes. Diabetes is the epidemic of our lifetime. And unless we can control some of these factors, activity and weight control, early on, by the time you're 65, you need to think about it and do these things. But these are activities that need to start, as you know, with the children that so many of you see in your clinics. 1 in 8 Americans 65 and over has Alzheimer's disease. We now have 5.2 million people diagnosed with Alzheimer's disease. By 2050, that number will be 13.2. Now, I have all the hope in the world that with all the technology and all the pharmaceutical research, we're going to change that number. There are things coming out every day on advancing knowledge, genetic changes, structural changes that can be adjusted with pharmacological tools. So we will hope that that number isn't going to happen. But when you look at healthcare spending, $183 billion now, $1.1 billion in 2050, and much of this is the caretaker. When we look at the cost of care, how many people have to leave the workforce and take care of their older parent or older loved one because they have Alzheimer's disease? So the billions of dollars that we spend are actually in care, and they also are in caretaker income loss. Workforce issues. It is a problem. We have very, very few providers who are trained in geriatrics. And why I'm here today is to tell you that without developing a workforce who is sensitive to the uniqueness of caring for older adults, we will not impact the health of our aging population. So it's really a matter of preparing that workforce. Caring for a 50-year-old is not the same as caring for an 80-year-old. As I just said, a 50-year-old who's in the hospital is not going to lose that mobility as quickly in 3 days as the 80-year-old will. So we really need people who understand that. So we need to educated workforce. The Institute of Medicine report in 2007 called Retooling for an Aging America was a call for action, underscoring that our healthcare system is really not ready. We are not ready to meet this impending crisis. When we look at the number of older adults, the number of multiple chronic conditions, the cost of caring for patients in long-term care, and the challenges that this unique population creates. Well, we've got a few chairs. There's one up here. There's one in the back. There's chairs. We've got about 5 more seats here yet. One up here. Physicians. How is the physician workforce prepared? Well, we've got about 650,000 physicians in this country. Very, very few of them are in primary care, and less than 2% choose this specialty every year. There is no money in primary care, and there's even less in geriatric primary care, where it takes you an hour to see a patient. So physicians really shy away from this, and they've got years of student loans to pay off, so they need to make money to do that, and not very many go into primary care. Most of them who are in primary care have no background in geriatrics. Today, we have less than 7,000 certified in geriatrics, physicians certified in geriatrics, and that number is decreasing. It's going down every year. There's only about 1,500 physicians who are certified in geriatric psychiatry. Now, those of you who work at all with older people, or those of you who certainly will, because they're coming, the behavioral problems in the geriatric population are immense. And when we look at dementia later on, not every patient, not every older person gets dementia, but a large number do. And over 85, the number goes to about one out of 2 people over the age of 85 have dementia. So it will be, these are behavioral problems that are part of this population. Most all programs, medical school programs, require some exposure to geriatrics, but not a lot. And less than 3% of medical students actually choose a geriatric elective. So if you have a choice, you don't do geriatrics. And not a surprise probably, but it is a fact. The projection of the geriatrician, the projection of geriatricians as part of the geriatric workforce has been done with a study. And when you look at these numbers, it's really quite remarkable. Now, you told me how to run the red here, but I don't remember how to do it. Is that it? Oh,
That's
there
it.
it is.
You got it.
This little dot up here.
Yeah.
When you look at this number, about 6.8 thousand geriatricians in 2010, and look at this number going down to 5.4 thousand geriatricians in 2050. In the meantime, look at the number of adults, and this is 75 and over, people 75 and over. And look at how this number is going up. So we've got an inverse relationship here, fewer physicians and far more older adults. So this is what, if you plot it out together, this is what the geriatricians per 10,000 people, 75 years and older, is going to look like as we move through the next, at this point, the next 40 years. Nurse practitioners. Well, I happen to be a big proponent of advanced practice nurses. They are a vital source of primary care for older adults. But, a big but, there is about 255,000 advanced practice nurses, about 250,000 advanced practice nurses. Less than 5,000 of them are prepared as geriatric nurse practitioners. We have about 25,000 who are prepared as adult nurse practitioners, about 55,000 who are prepared as family nurse practitioners, but less than 5,000 in geriatrics. 40 research studies have shown that patient outcomes from nurse practitioners in primary care are comparable to those of MDs. It's well documented in the literature, and now it's probably more than 40. This was a meta-analysis that was done about 2 years ago. Nurse practitioners cover about 80 to 90% of the services that physicians provide. There's no reason they can't be used in primary care. And in 2010, President Obama announced an increase in funding for RN manage primary care clinics, many of which are FQHCs, many of which you are a part of now. We have scope of practice issues. I see people nodding their heads. Depending on what state you are either independent in practice, you are collaborative in practice, or you are supervised in practice. So we have different ways in which nurse practitioners are practicing state by state. And I think it's done in some of the states that are really frontier. We have more independence because the states have no choice because there's nobody else to take care of the patients. Yet in the more densely populated areas, the nurses are supervised or in collaborative agreements. So we need a uniform way of addressing nurse practitioners' scope of practice. They need to be, I believe they need to be independent. I don't see anything wrong with collaboration as long as the collaborating physician allows nurse practitioners to do what they can do. Otherwise, you get the pinch put on you. So these are issues we have to follow up on in policy. We have to work with our policymakers to change this. But never before have we had so much to do and so little time to do it. And as I listen to all these talks in these sessions, I'm overwhelmed by how much we have to do and how little time we have to do it. The numbers, the social determinants, I think, are so overriding when I listen to all of you speaking. The social determinants are influencing our health care so widely that we could be working 24 hours a day, every day. We've got a lot of work to do. Primary care, I think, is special. It is the hub of care coordination across the care continuum. It is the hub. Care is where everything takes place, and it is the primary care provider who should be coordinating the care for that each individual person. Remember, person-focused care, patient family-centered care. Those of you who have patient-centered health centers all know this, that this is the drive, is to have person-centered care. We have prevention of transitional care issues if we have good primary care. In other words, when the patient moves across that continuum from primary care to the emergency room, to the hospital, and then back home again, or to the nursing home, if you have a good primary care provider and good coordination, there is there is good communication then across the transitions. Diagnoses are often a challenge, though, in older adults, which we'll talk more about. They're undifferentiated very often in older adults, particularly those with the multiple chronic conditions. It's hard to tell what they have. And then we have something called geriatric syndromes, which I'll talk about, which confuse the issues as to what the patient really has. There are family issues, family caregiver issues with older adults, and that's why it's so important to involve the family in the care plan. It is because people have to work or not. They may have to leave their jobs. It's a real drain on the sandwich generation, and I talk now about the Oreo generation because you have the great-grandparent, the grandparent, the parent, and the child. So many of us are in those various sandwiches there that we have many different competing pieces in our lives. And then the behavioral health issue for older adults. Behavioral health, as I said, is a major component of managing chronic conditions. And we must prevent avoidable function loss. So what's happening in today's environment in primary care? Well, you all know, first of all, you're being asked to do more with the same or less resources. And even though we are looking at the exchanges rolling out in October, we're looking at different payment plans. We're also looking at decreased budgets. Right now, we're all dealing with the sequestering going on in Washington. Nobody can make a decision. Nobody can move anything. We have major issues. But let's face it, we do have a major economic issue across our country. There is a limited amount of money, and we can't just keep printing it. So we are all being asked to do more with the same or less resources. But, you know, that's an opportunity. How do we do things differently and better? So I always look at these things as opportunities. It's, okay, so here's what I've got. But I can do things better. And when you look at the fact that we're 20th in longevity, I think we have a lot of room to do things better. We have a growing number of older people and longevity, so there's more chronic disease management. That's an example. We have never really focused on chronic disease management and what do we do with it. We've also never really focused on end-of-life care and not spending that $60 billion at the end of life. So right there, I think, are two opportunities. And there are more demands to maintain function, and that I keep driving home. How do we really keep people at quality life, help them to maintain their function, physical function as well as cognitive function? And cognitive function can be encouraged by keeping the mind active. So and being social, getting them out so they're not, people are not sitting in their homes every day. Quality, though, is a challenge to sustain. I just heard a presentation from a physician in New York who runs a very, very large FQHC with about 50 sites. Sees about 150,000 patients in his very widespread. It covers like a third of lower New York State. He said they focused, they were really concerned about depression, which I talk about a lot because I think depression is a huge problem in the aging population. And I think depression contributes to everything else too, because you don't want to go out, so you sit in front of the TV, so you get heavier, you get diabetes, you don't socialize. So I think depression becomes a cascade of things that happen. So they started doing depression screening in their clinics, and this was a quality indicator. And they had a 5%, when they started, their depression screen showed 5% of the population was depressed. Well, after 6 months, they found out that 45% of their population was depressed. But P.S., so they found this out. They don't have the resources. What are they going to do about it? They don't have the resources to cope with it. So they stopped tracking it. Because if you can't do anything about it, why are you tracking it? So when we talk about it, many of you are in the head of quality in your FQHCs. These are some real issues. When you have indicators and you're tracking them, what do you do about them? Do you have the resources to tackle it? And it's funny, once you stop doing it, it no longer is important. If you stop following, once you stop tracking and really focusing on that quality indicator, it goes down the tubes again. So you either have to stay very focused on those quality indicators. It takes a lot of energy for your practitioners to be collecting that data, doing whatever it is you're asking them to do. But on the other hand, if you find something out, what are you going to do about it? Do you have the resources, and how do you find the resources to do something about it? And of course, the onus has to be also on researchers who are then giving you the data that says it's far more expensive to care for these patients with depression than if we gave you the resources, social workers in every one of your clinics to handle depression. Maybe more than one, depending on how many patients you have. The other thing is patient engagement. We heard about it this morning in the session. Patient engagement, involving the patient and the family in setting goals. And I talk about this all the time in managing chronic diseases. What is it the patient really wants? And what does the family want? Do they want a longer life? Do they want a good quality life? Do they just want to be comfortable? Because we can't do everything for everybody. And if somebody says, you know what, I just want to be comfortable, and if I die next week or 6 months from now, it's okay. I want to be comfortable until I get there. And if that's their goals, that should be our goal. But what we do instead is we say, oh no, we have to do this, 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 and this, and provide you with all these treatments. So I urge you to go back to your patients and families and say, what are your goals? What is it that you want out of life? And make sure they are full partners with you in caring for that older person. That person and their family, they should be full partners with you. We have quickly changing evidence. You all talk about evidence-based practice. I've heard that many, many times in the last day and this morning. It is very important. It changes very quickly. So it's another opportunity for providers. You need to keep up with the evidence. You need to know what's going on because you got to be doing the latest thing that is evidence-based. One of the things we've also found is that referral follow-up. When you have one of your patients going out to a specialist, let's say you see a patient in your clinic and you say, you really got to see the cardiologist. Well, the patient tries to get in or they don't try to get in. If they don't do it within, if they do it within 3 days, if they get that follow-up appointment within 3 days, there's 100% compliance. They get there. Oftentimes, they can't be seen in 3 days. Maybe they're seen in 7 days. 70% compliance. And in many places, because transportation issues, because family getting to take you there becomes a real problem, and the physician, the specialist is busy, can't get to see you, so it's 2 to 6 weeks, 0%. People don't follow up. So this follow-up becomes a major issue, and then that's when your patient navigators, your care coordinators become very important to make that appointment happen soon. So when we talk about the triple aim, which is one of the CMS's goals, is better health, better outcomes at a lower cost. Is it realistic? And what a lot of people are finding is that we are doing all of these changes in healthcare and focusing on prevention. It's costing us more right now. So we're not there. We're not there. But most people say by 2020 we're going to start to realize some real savings in healthcare. So I just think we have to keep pushing, and the onus is on all of us. The Affordable Care Act, you've heard a lot about it, recognizes that the patient should be at the center of care. It shifts priority from episodic care to incentivize comprehensive care across the continuum, and it focuses on chronic disease management. I think these, and then I think the fourth one we heard this morning was on activity and healthy eating. So I think that, so it's keeping people healthy are the major pieces of it. Some of you, are any of you part of an accountable care organization? Have any of you become two major pieces of legislation that come out of the Affordable Care Act? One is the Accountable Care Organizations. It is an organization of providers that agree to be accountable for the cost, quality, and overall health care of a designated group of Medicare beneficiaries. So many times it's dual eligible, it's Medicare, Medicaid. So it is a group of systems. So it could be an FQHC, along with a home health agency, along with a hospital system, that work together and manage the patient for a set sum of money to provide them with better care, better outcomes at a lower cost. It's a risk, and a lot of organizations have been hesitant to do it because you're going to get a set amount of money from the government because you're going to say, this is what I need. And if you go over it, you eat the difference. If you go under it, there's a cost sharing. Some goes back to the government and some stays with you. So I think the jury is out yet on how effective accountable care organizations will be. And of course, many of you are part of or are a patient-centered medical home. This also was another major piece of legislation that came out of the ACA initiative around the delivery of primary care. And it's a partnership. So this is all of those things that we've been talking about, the partnership of the provider, the patient, and the family, the coordination of care. And the outcomes are really to reduce the cost, particularly chronic disease management, evidence-based practice, reduce avoidable use of the emergency room and hospital, and reduce the cost of drugs and adverse drug events. And I'll talk a little bit more about polypharmacy later on. How many of you are a PCMH? One. Okay. All right. Many FQHCs are becoming one, and it is, if you're level 1, 2, 3, or 4, your reimbursement goes up, depending on what level you attain. And it all has to do with these pieces that are on here: evidence-based practice, care coordination, patient family-centered care. Nurse practitioners are the future of primary care in this country. Nurse practitioners, I believe, are the future of primary care in this country. They provide accessible quality care regardless of the ability to pay. Anybody in here a nurse practitioner? Okay, but I see a lot of people nodding. So I know a lot of you work with facilities that have advanced practice nurses in them, and you understand the value that they provide. But since there are only less than 5,000 prepared in geriatrics, we need to increase the capacity of nurse practitioners to deliver age-sensitive care to the growing number of older adults. And this is something that the Hartford Institute takes very seriously, is developing the workforce. So we have a program called PCOA, the Primary Care of Older Adults. This is a project supported by HRSA, and it is a partnership of that we have at the Hartford Institute for Geriatric Nursing with the Community Partners for Sustainability and the National Nursing Care Consortium. What the PCOA is, they are online resources to help primary care providers, nurse practitioners, physicians, and PAs to provide age-sensitive care to older adults. So our hope is that this resource will help all of those primary care providers across the country understand the uniqueness of caring for older adults and therefore keep those people at better quality care, better quality of life, better quality of care, and appropriate management of chronic disease. It is interprofessional. We talk about team care because we say, you know, there's the social worker, the pharmacist. The pharmacist is hugely important in care of older adults. So we don't have people on 22 medications. Evidence-based practice, age-specific care. So we believe if we can enhance the capacity of the workforce to care for these older adults, we can keep them at their highest level of function. We conducted a survey. We conducted a survey through the Community Partners for Sustainability, and it was sent out to nurse practitioners across the country. We had 148 respondents. 96% of them said they needed more knowledge about older adults. So that was pretty profound and really gave us a reason to say this is a program that's needed. Only a quarter of them were certified in geriatrics. A little more than that, less than 5,000, you know, when we talk about 5,000 out of 255,000, but a quarter of them were certified in geriatrics. And then we asked them, what percentage of people that are older than 65 years in your practice? 75% patients older than 65, 68 people or 46% of the respondents said they had 75% or more of their patients were 65 and older. 18% of them said they had 50% of the patients were 65 and older. 17.5% said more than that 25% of their patients were 65 and over, and then there was 18.5% who said their patients were all younger. And as I've talked to many of you in the last day and a half, I've learned that, and I knew that FQHCs really grew out of the Mothers Babies initiative many, many years ago. But also what we're anticipating is that as those mothers and their children are getting to be 55 and 58 and 60 and 65, they don't want to leave their providers. They have a relationship with their providers. So we also believe that many of those people who have been with your systems over the years are going to want to stay with them. I mean, one of the things we find with the dual eligible managed care, mandated managed care that we are rolling out in New York State is that many people say, oh, I don't want to go into that because my provider is X, Y, and Z, and he's not in that, he or she's not in that group. So these are issues, but I think that a lot of people want to stay with their provider because they have trust in them. Our first release, which we'll be piloting it in New York State in July, and then we're planning on rolling it out, and I know the date is not good, but this was put into the HRSA grant a year and a half ago when it was written, and that was October of 2013, and we didn't know the exchanges were going to roll out in October of 2013. So I think we will have a little bit of competition out there as all of the FQHCs and nurse managed health centers are trying to get that taken care of. But there's 18 more months on the grant after that, so we think we'll have time. The topics for the first release came out of that survey, which we had put together, and we said, what is it that you really need to know about? And we have health promotion and disease prevention in older adults, and I'm going to give you a little preview of what some of these are. Common screening with older adults, cancer screening, presentation of illness in older adults, because, as I said, it's very different than the presentation of illness in younger adults. Dementia, we have 3 modules on dementia, which I'll talk about. End of life and palliative care is 2 modules, one on end of life care, one on palliative care. Chronic disease management, which really talks about the patient and the family. and how do you involve them, and how do you decide what you should do and shouldn't do, because after all, what is the life expectancy of the person? Are you going to do a colonoscopy on somebody who's got probably 6 months to live? So how do we manage those chronic diseases and maintain quality of life for those individuals? Chronic pain management and osteoarthritis. I was in a session here yesterday on chronic pain management. It is one of the major issues for physicians and nurse practitioners working with older adults is managing chronic pain. Making your practice friendly to the older adults, and medication management, polypharmacy. I'm going to talk a bit about some of them, and one of the first things I do want to talk about is the first annual wellness visit. This is Module 1, and I'm not going to go through the whole thing, but I want to give you some highlights of it. How many of you know about Medicare and the annual wellness visit that is part of the Affordable Care Act? One. I recently gave a talk to a community group of about 100 older adults and their children or caretakers. And I asked that same question, and out of 100, I had 6 put up their hand, and that's about right. It's about 6% of the population knows about the annual wellness visit. And once someone turns 65, they are entitled to a wellness visit, an annual wellness visit. And they get the first one, which is more comprehensive, and then they get one every year. They pay nothing out of pocket. There is not even a copay. There is a code, which I'm going to give you, which you put in, and you get paid for it. The provider gets paid for it. But the patient pays nothing. And all of you that are in with the resident programs, you need to know this, because you should be telling your people that the annual wellness visit they are entitled to an annual wellness visit. Why? Because it is assumed that if people do this, we're going to decrease the cost of care, because we're going to begin to think about what do they need for prevention. It's a preventive visit. They don't take their clothes off. It's not like an annual physical exam. You still need an annual physical exam. You don't take your clothes off. You go in and you have a conversation with your provider. They do a health risk assessment. And sometimes it's good to complete that 20 minutes. You give them 20 minutes to do it in the waiting room or something. So you have your health care assessment, and that is available on the Medicare site. You have all these forms on the Medicare site that will tell you what you need, what you should be assessing. It includes demographics, their own assessment of how well they are, psychosocial, behavioral risks, what are their activities of daily living, medical family history, have they had any medical surgical issues, what kind of medications are they on, are they depressed, do they feel as if they don't want to go out every day, do they feel sad, do they have mood swings, what is their functional ability, level of safety, general assessment of height, weight, blood pressure, detection of any cognitive impairment. Are they beginning as you talk to them? Are they confused? Do they seem to be confused about anything? And then you develop for them a written screening schedule for the next 10 to 15 years. You're 65. You don't need to be screened for everything, and I'll give you some basics on that in a moment. You don't need to be screened for everything over 65, but there are some things that you need, and you may not need them every year. What are the risk factors for which interventions need to be recommended or underway? Are they overweight? Do they smoke? Do they fall a lot? I mean, people over 65, you go to the doctor. How many of you are asked, do you ever fall? Falls are a major problem with older adults, and they lead to hip fractures, and they lead to long-term care placement. You can prevent the risk, or lower the risk. I shouldn't say prevent it. You can lower the risk. And there's things like Tai Chi, yoga, that are very, very good for older adults and help them maintain balance. But they need to know about it. We need to educate them about it. Nutrition. What are they eating? Are they eating well? Billing code. Those of you who do billing, GO438. And the billing description is the annual wellness visit. Includes a personalized prevention plan of service, a PPPS, initial visit. Copay is waived. So there is reimbursement. The subsequent annual wellness visit, which then every year the patient is entitled to come every year. for their wellness visit. And you update the information from the first visit so the follow-up ones are not as lengthy. Billing code for that is GO439. Billing description is the same. And you list it as a subsequent visit. So there are codes for these things. Encourage your older people to get out there and get it. Different, as I said, than your annual visit for primary care, which is a comprehensive health history, including medications. I always say to a patient who's 65 or over, when you come in, when you go to see your primary care provider, take all the bottles of your pills in a bag with you. Some people will say, bring a list. I don't think the list is as comprehensive because I think it's more important to see the bottle, see who's prescribed it, what the dosage is, because maybe what the dosage is not what the patient is taking. So medications are a huge, huge issue for older adults. So make sure, tell them, in fact, your office manager should say to them, when you book the appointment, say, bring all your pills, everything you take, bring the bottles in a bag, and we'll go over them. A functional assessment, how are they? What are they doing? What are they, how mobile are they? Social assessment, I go back to those social determinants and that are so important in assessing the patient. Do they have advanced directives in place? Advanced directives, have they talked about end of life? And there is a new format now called the POLST or the MOLST. The POLST is the P-O-L-S-T. The MOLST is the M-O-L-S-T. The POST is the provider's orders for long-term, for sustaining life. And the MOLST is the medical orders. So they basically mean the same. One is provider and one is medical. And what they are literally is a set of medical orders that the patient or the person can post on their refrigerator. So if something happens, do you want to be intubated? Do you want to have CPR? Do you want to have a tube feeding? So they are really orders for what you want done if something should happen. And they are a little different than advanced directives. Advanced directives say who is your designated person to speak for you if you're unable to speak anymore. So they're a little bit different. But and they supersede the advanced directives if they're dated later than the advanced directives. So if someone wrote advanced directives in March and they made up these medical orders in November, the medical orders will take precedence. But whoever is designated as the decision maker would be given on the advanced directives. So you need to have these. So you got to talk to them about it. And you go through the systems. Your vision, your hearing, your mood. Do you have a mood swing? Do you feel sad? Do you feel happy? And again, use of evidence-based screening and assessment tools. I can't enforce that enough as evidence-based. So your assessment and management plan should address the medical, the nursing, the psychiatric, functional, social, nutritional, occupational, financial, family, environmental, education, issues and needs. So if you just think of those, so just get your form with those things on, you'll have covered the gamut. And these will be, these slides are on, they'll be on the site, your site, I think.
That's correct. They'll be posted.
And they're also on the, they're on the what? They'll be on the Hartford Institute site as of October. You'll have access to all of them as interactive modules. They'll be there. Community health partners. In fact, you would just remind me, we did a webinar. The nurse practitioner who's working with me on this did a webinar on the annual health visit, the primary care, the primary visit, the cancer screening, and they will all be, the webinars are actually posted on the Community Partners for Sustainability. I wasn't sure of that. Yes, yeah, those are all posted on there. So we're running these, before we develop the interactive module, we're running all these as webinars to get, to see if there's any feedback and anything we should change. Immunizations for older adults, and I do think this is important for all of you to know, the residents, those of you who are with resident programs here, as well as those of you who are with FQHCs. What are the immunizations for older adults? The big ones are the flu vaccine. Every patient over 65 should have their flu vaccine starting October and ending in February. And you should that should be a quality indicator for your practice, is how many of your patients have had their flu vaccine. That is that important. The pneumococcal vaccine should be once after the age of 65 with a revaccination every 5 years. Older people die from pneumonia. They die. So you really want to keep your older person from getting pneumonia. The tetanus, diphtheria, toxoid as a booster shot, they should get that every 10 years. So remember on that annual wellness visit I just talked about, these are the things you want to set out an immunization record for them. The shingles vaccine. I have to use this as a platform to talk about shingles vaccine. People 65 and over should have the shingles vaccine, unless they're immunocompromised in some way. Shingles is an awful disease, and it is most common in women and women over the age of 65. Men get it too, but more common in women. It is devastating. So it is a kind of a chicken pox. And if you've had chicken pox as a child and you've not been immunized for chicken pox as you got older, now children have shots for chicken pox. Years ago, there was no such thing, and many people had chicken pox. And we thought we were just immune to it then. But the virus lives on in the body, and it can react and come out as shingles as you get older. Shingles vaccine, you should talk to your doctor about it. Screening recommendations. Mammograms should be done every 1 to 2 years for women who have more than 5 years of life remaining. So that's why I say to you, if somebody is very compromised with multiple chronic conditions and you really don't expect them to last for 5 more years, you may not consider a mammogram as necessary. But it should be done up to 85 if they are healthy, and longer if the health and function of the patient you think they would benefit. I mean, the question here, could the patient, if there was something wrong, can the patient tolerate the treatment? So again, if you've got somebody with multiple chronic conditions, they've got diabetes, they've got congestive heart failure, and they've got depression, are they going to be able to tolerate chemotherapy, radiation therapy, and all that? Those are things that have to be thought about. So if they can't, then there's no reason to do a mammogram. Cervical, no testing for those over 65 if they've had adequate prior screening and don't have HPV. Women who have HPV should continue an annual screening. Colon cancer. You should have a testing for occult blood, that's blood in the stool, so your doctor should have a stool sample once a year to check for blood. Otherwise, it can be anywhere between 5 and 10 years for a sigmoidoscopy or a colonoscopy. There's no upper age limit to stop screening, but I can't tell you how many people with 85, 88 years old with congestive heart failure who have black tarry stools showing there's internal bleeding have had colonoscopies ordered. And the reason they have it is they are really in failure. That's why they probably have liver failure, and that is why they are having the black tarry stools. These people with the multiple chronic conditions, can they tolerate a colonoscopy? And these are the things we need to consider as people get older. Prostate cancer, a yearly digital rectal exam should be part of every yearly physical for men. And then you need to decide if treatment is worthwhile or not. Geriatric syndromes. Geriatric syndromes, I think you may have heard a lot about them. They're not a specific disease. They refer to one symptom or a complexity of symptoms with high prevalence in geriatrics. And I'll talk about what these symptoms are in a minute. They often result from multiple diseases. People with multiple chronic diseases have more of what we call geriatric syndromes, very typical of older adults. They've got their broad category of signs and symptoms. They oftentimes limit, though, your daily living, your quality of life. And that's why geriatric syndromes can be a problem. These are typical of geriatric syndromes. Again, they're not a diagnosis. You know, difficulty walking, functional decline, falling, dizziness, syncope, hearing problems, vision problems, urinary incontinence. It happens with age. You know, urinary incontinence, there's prevention for that. You know, there's the strengthening of the muscles that women should be doing. So you want to prevent these geriatric syndromes. The falling, I talked about exercises. Functional decline, I talked about mobility, which would help you with walking. So the thing we all need to think of in terms of aging is how do we prevent the geriatric syndromes? And it's exercise. It is nutrition. And it is having your annual exams and following your health to see if you have any special needs that year. More geriatric syndromes. Frailty. Frailty comes from muscle loss. If you're not moving, you lose muscle, you become frail. You can, you know, when I say so-and-so is frail, you have an image that comes to your mind, right? It's probably somebody who doesn't walk well, is very feeble as they walk, they're shaky, they're apt to fall. A lot of this is lack of mobility. Pressure ulcers is just lack of good care. If somebody is bedridden and they get pressure ulcers, they're not getting turned enough. They are preventable. It is lack of good care. Delirium, dementia. I want to talk about delirium first. Delirium, I always say, is a medical emergency. If somebody who's never been confused is all of a sudden acutely confused, it's usually a sign there's something wrong. They've got an infection going on. They've got a urinary tract infection, pneumonia. Those of you who have older people in your family, I'm sure you've seen these things happen. I've got a 95-year-old father. Whenever he's got some dementia, but when he gets acutely confused, I say he's got to get a urinary, somebody's got to come and sample his urine. Is his chest clear? I go through all the things because it's a sign of something. It's a geriatric syndrome. It's a sign of something. Dementia, as I said, we refer to it as confusion. And, you know, a lot of people just kind of get forgetful as they get older. And I think of dementia more as that, occasional forgetfulness. However, if you really got clinical about dementia, dementia is Alzheimer's disease or other kinds of dementia. There's something that patients with Parkinson's disease often get called Lewy body dementia. And that's typical of Parkinson's disease. But dementia usually is Alzheimer's disease. Eating and feeding difficulties. You know, as people get older, a lot of them have no teeth. So what are they going to eat? So when you see these patients and you're trying to do prevention, you're trying to help them with good nutrition, what can they eat? Do they have teeth? And maybe they don't. Maybe therefore they only have soups and cereals and things like that, and ice cream. So you need to look at that. Sleep disturbances. Sleep is a problem, and then we get into this whole over-medication for patients who are older. A lot of people have trouble sleeping as they get older. And this is a real issue when we get into taking of narcotics, because when they take narcotics to go to sleep, they get up in the morning, they're dizzy. So it all feeds into this whole geriatric syndrome. And of course, pain, and pain, sometimes chronic pain is there. We talked about that. Medication use in older adults. I can't stress enough how they can lead to geriatric syndromes. All those things I just talked about often are the result of polypharmacy. Delirium is often a drug interaction, that you've got a patient with one and something else and triggers a reaction in their brain. So polypharmacy is something that every primary care practice needs to be controlling. And you need to know what every other doctor they're going to is prescribing, because this happens when people see multiple providers. And this one's prescribing that, and that one's prescribing that, and somebody else gives you something else, and before you know it, you don't know what the patient's on, and they're taking everything. So when somebody tells me they're taking 22 medications, I say, let's see what you can get off from. What can we discontinue in you? There is a tool called the American Geriatric Society Updated Beers Criteria Tool, which again, when the PCOA rolls out, all of this that I'm giving you, I'm not going through every item on these slides, but I'm giving you kind of a taste of what is going to be on the PCOA curriculum. The Beers criteria is really the benchmark for providers when they're prescribing medications for older adults, because it tells you what is potentially inappropriate and dangerous to older adults. It tells you what you should avoid and the drugs that can exacerbate certain symptoms, and those medications that should be used in older adults with caution. And then we give you the whole website to access the Beers criteria and other resources for it. And as I said, this is on here. Also, if you go to the Hartford Institute website, you can access the AGS website right through us, and you'll get all the information you need on the beers. All you need to do is remember the name, B-E-E-R-S, like the beer you drink. Managing polypharmacy. How much more time? 5, 10 minutes?
Yeah, 5, 10 minutes.
The first thing you need to do is you want to reduce the dose. A patient should always be given the lowest dose possible when starting a medication, the lowest dose possible in workup. And as I said, discontinue unnecessary therapies if you just increase the risk of an adverse event. When a patient's starting a new medication, this is as important for the family as it is for the provider. When a patient's put on a new medication, you want to know what are the possible side effects. The patient should know it, or the caretaker family should know it, and watch for them to see if there is something going on. And I think that this is the second one, avoid the prescribing cascade. This is an important one because so often a patient gets a symptom, like I talked about with the geriatric syndromes. They get a symptom such as dementia. And right away, they're prescribing a medication. So instead of prescribing a medication that may have an adverse effect, look and see what they're on to see if something else they're on is causing the confusion. Presentation of illness in older adults, and this is why providers need to know how to care for older adults, because it's very different. It's a vague presentation, altered presentation, or actually a non-presentation of illness. Common diseases with altered presentation, and these are many of our chronic diseases: cardiac disease, diabetes, thyroid disease, depression. Pneumonia, for example. You need to assess the patient for increased respiratory rate, decreased appetite, change in mental status, or change in function. These are all signs of pneumonia in an older adult. They wouldn't be in a younger adult. You wouldn't have it. You'd have a cough, and you'd have fatigue, and then you'd listen to the chest. Urinary tract infections, urinary incontinence or frequency, change in mental status, change in function. Skin infections. I've seen nurse practitioners in clinics do this, and I've never seen a doctor do it. And I have all the respect in the world for geriatricians and primary care practitioners, but I've seen a nurse practitioner actually take the patient's socks off and look between the toes. And that is a good physical exam if you are looking at the toes, because that's where there's a lot that you can tell from a patient's feet. Their circulation, their signs of infection are all things that are in the feet. So skin texture, dryness of skin. Note, older adults when an older adult has a fever or an increased white blood cell count, they may not even have the fever or an increased white blood cell that younger people have. So they may have pneumonia where the younger person might have an increase or an infection, where the younger person would have a fever, chills, and high white blood cell count. The older adult may not have it at all, but they'd be very confused. So these are things that you need to know, that providers need to know. Congestive heart failure increases incidence with age. It is a leading cause of hospitalization and rehospitalization in older adults. I would guarantee you that in any of your practices, any of your FQHCs, it is the primary, it's the leading cause of hospitalization. Annual expenditure exceeds $10 billion. The good news is we have technology on the forefront here, and a lot of patients are being controlled at home with telemedicine, so that patients with congestive heart failure actually have a machine that they get on that weighs them, takes their blood pressure, measures how much oxygen is in their blood, and asks them how they feel. And those results go to the doctor's office. Now, problem is it accessible to everybody? Do all of our patients in all of our different socioeconomic stratospheres have this? No. So these are some of the issues we need to think about. You know, we do have technology out there. We need to get it to the people who need it the most. So these are some of our opportunities. Again, just to quickly, the classic signs in younger adults of congestive heart failure are very different than they are in older adults. The decreased appetite may be your first sign of a worsening disease of congestive heart failure. They're gaining weight, they've got increased respiratory rate. Where in younger adults, it's really on the EKG. You can take an EKG on a younger adult and you can tell if they've got congestive heart failure. Not true on the older adult. MIs, a heart attack. Of the approximate 1.2 million heart attacks annually in the United States, 2/3 of them occur in people who are over 65, and 44% of those are in those who are 75 and over. And when you look at the mortality after an acute MI, 80% of the deaths occur in those 65 and over, and 60 occur in those 75 and over. And here's again where I talk to you about advanced directives. You know, if you're going to resuscitate somebody who has multiple chronic diseases, and you are resuscitating them to have a very poor quality of life, a very costly life to both their caretaker as well as the system, you need to think about what is the right thing to be doing here. Again, acute assessment in older adults. You know, in a young person, chest pain and sweating is a classic sign of an MI. In an older adult, sudden onset of breathlessness is the most common symptom, initial symptom, but they could also just have confusion, be dizzy, have anxiety, and loss of consciousness. Diabetes. Prevalence is about 1 out of 5 of those over 65 have diabetes. And those of you in your clinics, I know you see this, in your residences, you see this from early age all the way through. And I just think that this is going to be a huge impact on our population as the younger people age, because it's affecting their cardiovascular system, it's affecting their entire wellness. So this is going to be a bigger issue as we go along. And again, different signs, different presentations. So diagnosis, that's, I keep saying, this is why, how do we change this? We need to have people educated to understand these things. Thyroid disease, I think the important thing in thyroid disease is hyperthyroidism. Treatment is not going to help you return to normal cognitive ability, but it will improve cognition, functional ability, and mood. So if an older person presents with a hypothyroid, the treatment's not going to cure it, but it's going to help them, so they should be treated. And again, different presentation for thyroid disease. Depression is, again, such a big deal in older adults. 8 to 40% of older adults in primary care do have depression. The common presentation is, I don't know, how do you feel? Well, I just don't know. Or what are you going to do tomorrow? I don't know. What did you do today? I don't know. It really is a problem, and the intervention for it is really some very good a social worker, a neuropsychiatrist, a psychiatrist could really help, because medication can help depression in the older adult. There are all kinds of screening tools, which are, you can see them on the Hartford site. This is one I do want to just take a moment with, because we have already published 3 of our dementia resources, which will be part of the BCOA program. They are on our website because we also had funding from another foundation who is testing it for us. So these are available on our website there now. The first module is on mild cognitive impairment and Alzheimer's disease. It's evidence-based practice for the primary care provider. The second one is a collaborative care approach to memory disorders in primary care. So it's the role of all of the other professionals in primary care. The third module, I think, is one that all of you would find interesting because it's for the patient and their families. It's the patient self-management resources facts and question sheet. And we have 4 different sheets. One's on Alzheimer's disease. There are questions, and what is the answer, and what are the resources you could go to. So it's on the computer. It's downloadable. You can print it, or your provider can print it for you. The second fact sheet is questions and answers and resources for those with mild cognitive impairment. The third fact sheet is for the family member of an older adult diagnosed with Alzheimer's disease. And the fourth one is for the family member and older adult diagnosed with advanced Alzheimer's. So these are good resources for any of you, for those of you that are in the residency programs or for those of you who are providers. With dementia comes other comorbidities. I don't know which is the chicken and which is the egg. Do you get the comorbidities and then get dementia, or do you get dementia? Does that contribute to other comorbidities? Almost 90%, 95% of people with dementia have at least one other chronic condition. And then on our website, we have a whole bunch of tools on the Hartford Institute website, which are part of our BCOA program, which will refer you to ways in which you can assess cognitive impairment. So in summary, call to action. The time is now. The time is now. It's a tsunami out there. You people live it every day. My concern, what we're talking about here, is the tsunami of the older adults, and you have older adults, and if you don't have them now in your practices, you will. So the time is now. Chronic disease management and care coordination, patient-family-centered care, and prevention and wellness. We heard it this morning, the 4 pillars of the Affordable Care Act. These are things we need to focus on. And we have to have a care system that, and also the interprofessional care team. Everybody has a role. The scope of practice of each of the RN and the NP are critical. And we have to have a care system that is seamless, with a value for quality of life and the highest potential for every patient. So go out there and do your thing. Thank you very much. Shall I take questions?
What I'd like to do is, in my opinion, summarize this session with one word: wow. I initially, for those of you who came in a little bit late, was a very long introduction of Dr. Cortes. And I indicated that she had a distinguished career spanning executive leadership, nursing education, research, and practice. And I think you clearly could see all of that in this presentation. What she has provided us, or at least me, is a wealth of information that I think most of us can take back to our community health centers. And those of you who may be residents in public housing will be able to take back to your public housing, to your resident organizations, and share with your neighbors. Senator Ted Kennedy was a great friend to community health centers. And oftentimes when he would meet with community health center organizations, he would always like to joke with the participants in the audience. And he would often say, when he first ran for office, he said, "Please give a young man an opportunity, vote for me as your senator." When he became older and younger people ran against him, he would say, "Please vote for me because I've got a lot of knowledge and experience." And I think those of us here today now have knowledge and experience that we can take back to our respective organizations. Any questions you'd like to ask Dr. Cortes? Because, quite frankly, I have so much, I think I would take up the next 20 minutes, and we're somewhat limited on time, but I do want to give you an opportunity to ask any questions. Anyone who would like to start?
I don't have a question, but what I do have is experience of going through my mom. It hasn't been dramatic or anything, but as soon as I felt the thought of coming on her, not remembering, but not forgetting that much either. That right there told me I don't want to go any further. So I took her, they checked her out, and they said she's just barely at the stage. So I keep her active. I take her to the seniors, what do you call it? Old age homes or whatever they're called. Anyway, and she reads to them. She keeps active and shows them that you don't have to go.
Oh, I was going to say senior care center. So you're actually taking her to long-term care places where she is reading and doing things for older residents. Isn't that wonderful?
And she walks around. She broke her hip, as I said about falling. Okay, she fell off the hip. She broke her hip. They replaced it and everything. I told her, I feel very quickly, lady. We're going to keep walking. She did. She continued after her rehabilitation. She continued. And I'm so proud of her. She just goes around, you know. I'm so proud of her. And she's going to be, her birthday is in July the 1st. She's going to be 89 years old.
Wonderful.
She still drives.
So she's got a good caretaker. You take good care of her. That's great. Thank you. I saw a hand over here. Did you have your hand up? No.
And I think that was a very interesting comment that you made, that even myself in this presentation, thinking of either my own mother or neighbors or relatives. So I think this is something that, again, we can take back to our organizations, but also take back at home with our own families. Yes, ma'am.
I have a question, and that is, what about caretakers who are being involved with the treatment plan, but are not getting assistance from an adult daycare program for that particular senior? Example is like the medications that you said. One person is taking 18 medications, and the family member is asked, my mom is 91 years old. Does she have to take 18 medications in the morning? Why is she taking 18 medications? She's bedridden. She's immobile. She doesn't get up. She has no mobility at all. She uses a hoist. She's obese. So, what can be done to assist that family member to go beyond that scope and get assistance?
I just realized I'm supposed to repeat the question because they're recording this, so I will try to repeat it. The question is what to do about a patient who is on 18 medications, is 91 years old, is bedridden, and can't get anybody to reduce the number of medications the patient is on. So is the patient a primary care provider?
Yes, she's in a program where she has all of those provisions provided to her at the program. So she gets her primary care there, her dental care there.
Okay. I would ask the primary care provider what medication she can come off of. And say, we really think she's just on too many medications. What can she come off of that without adding a risk, and maybe even decreasing risks?
And it's always good because they were trying to give her a lot of medication. She only taking 2. One thyroid and her gout.
Mm-hmm. Good for her.
I told them, no, I need a second opinion. I call and they said, well, what is she taking now? I read it to them. I said, keep her on that. I told them about her thyroid. What is she taking now? I told them, she's doing good.
Any other questions? Can someone share with me how you would take this back to your organization? What did you learn from this session that you felt that you could take back to your organization? Yes, ma'am.
For us, like we live in a place where the quiz, I don't know if everybody knows the quiz, but anyway, we live up there. There's a lot of seniors that I see that are not knowledgeable on a lot of things. Their doctors and nurses or whoever are not giving them the knowledge. I don't know if their kids try to get all this so that they can take it back to them. But I felt like I was talking to Rob and I said, let's go check out this one because we can help the seniors over there. We can help them, I mean, I would like help when I get older if I'm not able to attend them. I would like the knowledge to know what everybody's learning out there. So I feel like we can take back the community knowledge that we didn't know and they could learn.
And to follow up on that knowledge is also important because when your children say to you, let's go for a walk, or let's get you out of the bed, or let's turn off the TV and have a conversation, you'll begin to also understand why it's important that way as well because you've got the knowledge, because you understand what needs to take place. Yes, ma'am.
I'm just going to comment on what can you take back. And to me, it's the whole program that you have and side effects. It'll be a wonderful resource for our practitioners.
Great.
Good, thank you.
Great.
Yes, ma'am.
I work for senior housing, management and stuff there. There's so much. I mean, I've been there long enough that now you recognize when you see people going through certain things. It just makes it very difficult. I feel very limited on what control I have over what's going on. We had 4 years ago, there was a gentleman who at 92 was extremely active. He built bird houses and fed the birds and walked every day, and he was very active. And his doctor had him wear something at night to find out what his heart was doing at night, and found that his heart slowed way, 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 way down. And the doctor convinced him to get a pacemaker. A year later, he ends up in a nursing home, and he's still alive. He's still in the nursing home, but he doesn't know who anybody is, and he doesn't. His quality of life is very limited. Where if he had not gotten the pacemaker, maybe at 93, he would have fallen asleep one night and not woke up. You know, and I just wish there was a way to stop that kind of thing happening.
It's what you're bringing up here is a big ethical discussion. You know, I think it's easy. I can talk very easily about other people's advance directives and what one should do, and when it's your own, all of a sudden as well, I don't know that I want to do this, and let go so easily. But that's why it's important when the person, I mean, everybody here in the room, even if you're 25, should have told somebody what you want, because you don't know what's going to happen. And that's why it's so important to have the discussion so that you can decide, rather than making this ethical decision the responsibility of somebody else.
And one of the things you can do, and it came up earlier, we will have this on our website as a podcast. I know the other group will have it on their website as well. I encourage you to get the website addresses. I think it's here in your booklets. If not, talk to some of the staff at the desk. And please run this podcast or this webinar for your group. There is no way in the world I could repeat what the doctor said in any justice, and some of you may feel the same way. But if you run the podcast, education is important. Yes, ma'am.
I just wanted to, this was very timely for me to be a part of this workshop, to bring it back from Boston, Massachusetts. And right now, the Boston Public Housing Authority has just terminated all of their senior care case workers in their senior buildings. In a week's notice. So residents weren't prepared, so now they have no one there to do referrals, interventions for them, and the residents are left on their own now. So me being able to bring this information back to those developments will help those residents.
Well, what I'd like to do is give Dr. Cortes a warm round of applause, because I think this was very, very important. I'd like to thank all of you as well. You sat here for the hour-and-a-half period. I think she's phenomenal. She spoke on her feet for an hour-and-a-half and kept us all interested, but you all sat in those seats and were riveted as well. So I'd like to thank you all. Lunch will be served downstairs. Thank you.
Thank you.
Very well,
Thank you.
Thank you.